Yeah, so it's been nice to have cilta-cel as outpatient because it just happens that the CRS doesn't happen until around day 5 to 12. And so most of our patients will get lymphodepletion outpatient, then they'll get their CAR-Ts outpatient. And then usually right when they have the first fever is when we admit them. And again, it's not the idea that, oh, because they have a fever, they have to be admitted, but if a patient does end up with grade 2 CRS or grade 3 CRS, we want them to be in the hospital where we can monitor that and quickly intervene with tocilizumab and those types of things if needed. But really, our patient population, we have done really well. So on average, we'll have this data out soon, but our patients who are given cells outpatient, they end up in the hospital for only about 4 to 5 days during their CRS period, versus patients who are given cells inpatient and then stay until they're done with their CRS. It ends up being between 10 to 15 days for those patients. So we've been able to successfully reduce that hospitalization by half or even more for most of our patients, which then, again, improves quality of life because patients aren't stuck in a hospital. But it also helps us, in terms of hospitals that are full all the time. Sometimes we have to delay patients if we don't have a bed. And now, if we can do it outpatient, we don't have to delay cells, things like that. So hospital utilization, even financial toxicity potentially, where we're not just taking up a bed when we don't need it, could really actually improve that access piece to get more patients the ability to get the CAR-T.